Welcome everyone. This is Patricia from the Hospital Federation. Thank you for joining us in our webinar, Secure Hospitals in Insecure Environments. This webinar is being hosted by the International Committee of the Red Cross, or ICRC, and our presenters are Erin Downey, Health Advisor, Health Unit, and Federico Citaro, Strategic Planner, Health Infrastructure, Water and Habitat Unit at the ICRC. Just a few reminders before we proceed to the presentation. All attendees will be on mute throughout the webinar. Feel free to ask questions during the presentation. You can do so by typing in the questions tab on the right-hand side of your screen, and we'll try our best to go through all the questions after the presentation. The recording of today's webinar will be available at the IHF website next week. We will be sending you the link via email. You can also view previous webinars on the IHF website. You can also download 2 additional reference materials from the Handouts tab in your control panel. One is a concept note on the security survey for health facilities, and the other is a publication that discusses issues relevant to the security of healthcare facilities located in or prone to armed conflict and other emergencies. It also has recommendations to enhance the preparedness and security of healthcare facilities. It is with pleasure that I introduce our webinar presenters today. Erin Downey has worked within strengthening crisis response for national healthcare systems for more than 15 years. She is currently serving as health advisor at the International Committee of the Red Cross, or ICRC, for the Healthcare in Danger project. Dr. Downey leads the Healthcare in Danger Communities of Concern, convened by the ICRC, and provides guidance on the project's direction. She plays a vital role in mobilizing health organizations at global and regional levels to carry out activities at national levels via their members' country networks so that national health protection frameworks can be strengthened. Our other presenter, Federico Citaro, has been working for a number of development and humanitarian NGOs in different parts of the world for the last 15 years. These included 5 years with the MSF, focusing on WASH and public health engineering. And since 2014, Federico joined the ICRC as construction project manager based in Geneva. Federico has also been working on technological forecasting and strategic planning. He designed and tested the security survey, which will be discussed in today's webinar. Erin and Federico, welcome and thank you for joining us today. We look forward to learning about the security survey for health facilities that you develop. So I'll pass it over to you now for the presentation.
Thank you, Patricia, and thank you to the International Hospital Federation for also hosting this webinar, as well as the coordination efforts that have been involved, and very much appreciated for this. My name is Erin Downey, and I am, as Patricia said, the health advisor for the Healthcare in Danger initiative. Today we're going to be talking about the hospital security survey, and I'll just be providing a brief overview before we get into the survey itself. Just as a session overview, as I said, I'll be providing just some of the activities that were leading up to the security survey itself. Federico will discuss the survey, and then of course we'll have time for questions and answers. So we encourage you to take note of any questions that you might have, and we'll make sure that we have time to discuss them and address them at the end of the session. Just a quick note to all of you, we had about 75 registrants for this webinar, representing about 34 countries, and within that mix is a really healthy mix of hospital representatives, academics, universities, and several ministries of health, representatives from the WHO, as well as other colleagues here at ICRC. When we look at the endpoints of violence that's been occurring within the healthcare field, we've unfortunately have been aware of it for some time now. We've typically been looking at it in terms of physical locations of health facilities, health spots, health sites, as well as the transport. And then, of course, the people, the healthcare workers, and the wounded and the sick that are involved in providing that care. And we also are aware now of health security staff that may not be actually providing care, but be protecting that care that's being provided. we're seeing, and those activities that contribute to that violence come in a number of forms, which are listed here. They're certainly not limited or restricted to any one area, but we are noticing significant trends in violence. I want to mention that there's a fifth area that we're also noticing, which is the health and medical systems. In here, we'll see violence that occurs in ministries of health, potentially universities, medical supply chains, and or bureaucratic blockings to receiving care and or medical access. And so that's why access is one of the main issues that we look at for all of these endpoints of violence. One of the things that drew the attention to the ICRC to start to address or to see what the magnitude of this problem is a background study that was done well back into 2012 to 2014. Essentially, what this study showed us was that we know violence is occurring, we know that it's occurring in many different locations, we know that there's a variety of perpetrators, and that it's occurring at the local level. Essentially, what this means is that there's a real strong need for evidence-based data collection, and that's why the ICRC uses this as one key area for focus. I want to say that within this violence in healthcare that there are many, many colleagues that are also looking at this difficult issue of violence, where it's occurring, what are the impacts, etc. And on the screen here you'll see many of our colleagues as well as those that represent universities, database collections for different types and different points of where the violence is occurring and who might be conducting that violence. Secondly, I want to say that as part of the background leading up and into this webinar is before the project or before the initiative really as part of its getting underway, there were 10 global consultations, of which one was focused specifically on the preparedness of security of healthcare facilities. 2 expert consultant working groups occurred during this time, and that's what's led to the development of this webinar as well. The main, the document here on this screen, Ensuring the Preparedness and Security of Healthcare Facilities in Armed Conflict and Other Emergencies, is one such document that really gives the background of what these working groups identified as priorities and what ultimately led to the development of a working group specifically for the tool. I want to mention that at the end of this presentation you'll have the resource center where many of these documents can be downloaded, as well as many of the other resources that the Healthcare in Danger group has put to the website. Finally, a second strategic direction that we're focusing on, in addition to evidence-based data collection, is the communities of concern and action. Here on the screen you can see many of our partners that are working very closely with us to collaborate on the global level, as well as using their national linkages to help implement strategies at the local level. CEO of the International Hospital Federation, Erin Downey, chaired the Community of Action for this security tool. And here on the next screen you can see, or the next indicators, you can see the different organizations that actually contributed to the development of this tool. These represented the communities of action, the community of action. And simply put, the difference between the community of concern and the community of action is that the community of concern really focuses on the global level. They may have those national linkages that I mentioned, but they also may be academic or policy experts. And they do advocate for the protection of healthcare via a multitude of activities that they conduct. The community of action is more of a working group that identifies a specific or unique need, and through that working group, applying their expert knowledge, creates a solution or something that can be used at the operational level. So finally, coming to the third priority in the strategic direction, is the field-based operational effectiveness. And this is where this community of action has developed the hospital security tool. The tool itself is here. We'll be discussing it just next. And it assesses the preparedness levels of the healthcare facilities and identifies priority measures. I want to say, and finally, that part of our partners that also developed this tool were the World Health Organizations, and specifically the Pan American Health Organization. It's important to note that a hospital safety index exists. This tool really works alongside. I mean, the two tools can be used for very different contexts, but together are an important contribution to the preparedness of facilities and identifying where their security measures can be strengthened. The Hospital Security Index is an index for a broader community assessment, major emergencies tending towards natural disasters, and provides snapshots of the facility, the likelihood that they'll be able to continue to function after an event. The security tool really that has been developed by ICRC is really more for a rapid assessment. It can be applied to temporary facilities, hospitals. We've had it applied into healthcare clinics as well, and it's applicable more for the conflict context. I want to say in closing, before I hand it over to my colleague Federico, that both PAHO and the World Health Organization were represented on this working group to develop the hospital security tool. So I want to thank you both, thank you all so much for participating in today's session. As I mentioned, the website is located here, and a thanks to Agnieszka Kowinski, who is also one of our colleagues here that has helped put this on. Thank you.
Hello, good morning, everybody. As it was already introduced, my name is Federico Sittaro, and I will introduce you to this tool that we developed, and I will also show you a little bit the dashboard that is associated to it, so that you really can have a grasp of what actually is. So first, what is the actual operational scope that this tool was committed to address? It's really to answer an operational question, how we can assess and therefore choose between facilities that present security concerns. It's a risk assessment, and therefore it's based on an analysis of the context and an analysis of the facility itself, how it is equipped, prepared to answer to that risk profile. So what we did, we basically set up a set of questions that are designed to answer to that question and define a level of preparedness of the facility itself. This is, as was already mentioned, pretty much inspired by the great work that the WHO produced for the Hospital Safety Index. And we really use the same structure. All the questions are, we are talking about approximately 50 questions, are organized in the same way. They describe a specific subject, a specific content that we are trying to address, and they are proposing what we call micro scenarios for the answers, meaning that the assessor, or better, the team of assessor that is dealing with the survey has some reference in order to provide an answer that can be compared to other situations. So what this produces is a process that is a vulnerability assessment, where first we define what the risks are. And in this specific case, there was a kind of what we called a pragmatic funneling, meaning that the type of hazards or risk can be many, but from a preparedness point of view, the type of measures that we consider, they are actually not endless. They are quite limited. So what we did is that we cluster the type of hazard corresponding to the type of measures that we could implement. This brought to a short list of 3 main risks that are heavy weaponry, meaning bombs or big explosion, intrusion, that is something that is considering, let's say, both intrusion meant to steal or to present damage to the property, or intrusion with an aim of violence towards the health staff or the patients. And then we consider another category of risk, that is everything related to a mass influx of people, not only wounded, not only casualty, but people in general into the facility. If the facility is perceived, as sometimes happen, as a safe haven, it can be flooded, let's say, with people, which might cause a serious set of perturbation to the normal activity. So once we are able to define what is the risk, and therefore what we need to be prepared for, we look at the facility. The facility is a combination of hardware and software. It's a combination of physical infrastructure, and maybe more importantly, it's a mix of people, procedures, equipment, and policies. So what this set of questions do is really to go through all these aspects that you can see, let's say, the main categories, the main title in this wheel at the center of the slide, that really try to address all the different aspects of keeping a facility prepared. Then the tool, and this is, if you want, the smart part of the intelligence part of the tool, is combining these two very contextualized piece of information with what we call an expert scoring. So there is embedded in the file that is attached to the manual, there is embedded a kind of weighting sets that allow to specifically link the risk assessed in that context to the actual situation of the facility. So the scoring that are provided, assessing, for example, preparedness of the staff in terms of safety, or what is the external exposure of the building itself, all these facets are weighted according to the specific risk profile that is produced. So this brings, in terms of results, with a quite detailed profile of the vulnerability of the facility itself. So it really gives, and you can see the results are provided with this wheel that try to really grab the attention of the decision maker in terms of what needs to be addressed. It provides key indicators that are supposed to really answer the initial question: what is the level of preparedness? What is the risk associated to the context? And therefore provide the necessary inputs for the decision maker to decide, for example, to intervene in a context where you might have a high set of risk and a lower and a low set of preparedness, versus another context where as well you have a low set of preparedness, but maybe also a lower set of risk. So if you have to choose where to act between the two, you clearly go where the risk is higher. And as an immediate results, immediately available for the assessor team, it also provides a very specific list, or short list if you want, of intervention that should be prioritized, because those are the one that, according to the set of recommendation embedded in the tool, they will provide the greatest improvement in the final scoring and in the final results. So as you can see, it's a very practical and operational approach to the issue, really meant to provide a quick tool. It can take, of course, it depends on the knowledge of the facility, but from few hours to maybe a couple of days to be performed, of course, depending also on the size of the facility. But it's really something that is meant to provide the initial step of checking all the aspects, again, hardware, software, all together, all combined, and quickly define what the priorities are. So in this picture, which is now a little bit outdated from last year, we monitor. It's a very informal monitoring because the way the organization works, it's pretty decentralized. But at that time, we assess around 60 facilities. Now we think that we are a little bit closer to 100. And apart from the specific results, what is really an added value is the process, is how this, the application of this tool has brought together expert and responsible of all the different ingredients that are necessary to run to prepare the facility to answer this type of events. So with a little time left, voila, I would like to show you, as I said, this tool comes with a manual that is a text. You can download it in the website. I will provide the link at the very end, and there is a file associated. This is really to provide an immediate, the moment you fill the survey, the questions on the file itself. You can see this is a list of questions that should be answered with a preset set of scores. Results are immediately available. So as you can see here, this is for a demonstration dashboard, but it's the exact same layout of the file that you can download. It's meant to provide results in a way that, first of all, take the facility as a whole, and as you can see, starting from the left, it's really providing a score of the preparedness, low, average, high. It's, as I said, it's providing on the right a assessment of what I was trying to say before. What is the level of risk, of hazards? What are the level of exposure of the facility? These two indicators combined should provide all the necessary information for the decision maker to decide where to put the priority. Then, of course, there is a lot more that can be exploited. And for example, here, these indicators are illustrating the level, in this case, of the what you can see here. The blue is what actually is already done, and the white is what is left to be done in terms of preparedness measures. Keeping also in account that according to the vulnerability of the facility itself, in the specific context, there are certain things that can't be mitigated. Just to give you an example, one of the questions is to assess the general layout of the facility, meaning that if, for example, you have identified heavy weapons, bombing as a major hazard, and your facility is located in a building with multiple floors, that is a vulnerability. One hit, one bomb can affect the whole facility. If instead the facility is located in a campus-like structure, so many different buildings located in a wide compound, one hit might affect one building, but the rest can function. So you can see that this is a typical example of a vulnerability that is embedded in the facility itself, in the general layout of the facility, and can't be changed with this type of measures. So it's something that should be accounted as such, and therefore provide that type of information. Then continuing to show what the dashboard provides is, for example, here is a representation of the local assessment of the risk, and you see in this case bombing is not included, but instead we have a big concern about intrusion. Therefore, the type of measure should be the one protecting from that specific risk. So, for example, the tool will suggest that a typical prevention for intrusion is monitoring and security at the gate point. It's the level of the doors, is the quality of all opening, windows, and etc. And those measures are particularly relevant for this profile, but again, they might not be extremely relevant for bombing, for example. So there is a high level of contextualization in this assessment. So if I go down, there is a little bit more of detail that is proposed. Starting from the left, in this case, you see that, okay, we are not that bad in terms of infrastructure, but the vertical axis is measuring what is the level of management, and in this case, it's very poor. Of course, this is a random example. But then we can move at the center what is called priority action, and you can see here that 5 main actions are proposed. As it makes sense, you saw the profile of the risk. Lighting and fence clearly are things that are meant to provide a response to intrusion. The set of key indicators continue. Here is again a matrix helping to take a decision comparing the level of hazard versus the confidence that you have in your assessment. Of course, it's very difficult to predict the future, so there is a confidence level in the level based on the information that was available, and this indicator is trying to measure all this. And finally, there is this wheel that you already saw before, that is keeping, sorry, I'll try to put in a way that is readable. It's trying to put everything together. So it's meant to provide a very visual and eventually compelling indication of what is the situation. So the wheel is meant to illustrate that at the center what is blue, and the darker the blue the better it is, the indicators that are positive. And instead, moving outwards, you will see it becoming red, and you see the points where actually there is work to be done. In this case, you see that contingency planning is a sector that needs to be worked out, as well as fire protection. So it's really trying to put everything together, all the different indicators, and at the same time providing the suggestions and the recommendation. So I think that this is what I wanted to show you, and I hope that there are questions and we can better exploit and discuss this issue.
Thank you, Federico. Thank you, Erin, as well. We'll start reading some questions from the audience shortly. Just to remind everyone, you can send your questions by typing them in the questions tab under the GoToWebinar control panel. So I also have a few questions. My first question is for Federico. What are the main lessons you learned from the implementation of the security survey so far?
As I said, I really think that the kind of feedback that we got is I would say is twofold. There is a first component that is specifically related to the specific issues, the specific domain of prevention. So, for example, I can say that a quite general weakness is actually what was illustrated before, is fire prevention and in general contingency planning. Those are two points that are clearly highlighted as general points where we need to work. But I would really think that apart from this, if you want, quantitative indication, what with feedback, talking with people who implemented the process, I really believe it's more a process than a tool. The greatest added value that has been highlighted is the fact that performing this process brings different stakeholders around the same table, brings all of them to face this process that is constructed in a way that is inclusive, that really puts, okay, we have this risk, we have to all agree that this is the risk profile, and then everybody is involved, because the managers are involved, the technical, the administrator, the clinical staff, as well as the infrastructure and the maintenance team, and etc. They are all involved, and they all have a word to say. They are all essential to the process. So this really has brought to very constructive and fruitful conversation around the facility itself and the understanding of the functionalities of the facility that need to be protected in case of a security event. So I really do believe that this is the greatest added value that this process has brought in our operations.
Thank you, Federico. Another question is, does someone who wants to conduct the survey need to have technical or engineering background?
As I said, it really depends on the facility itself. If you are alone and you have to assess maybe a small clinic, the process, the questions are flexible enough that allow, I would say, whatever the background of the assessor is, to provide a certain level of answer. Of course, the more the facility get complex, get big, and with more services and more functions, then of course you need to have the right people around the table, which it's not necessary, as I was saying before, engineers or infrastructure related background. It's really the whole component. Is the management, is the administration, is the health providers, as well as the infrastructure responsible. So it's really the whole panel that should be involved.
Thank you, Federico. We have a question here. Is risk of cyber attack addressed in the security survey?
This is a very good question. Frankly, no. It is not an issue that as such has been included in all the panels that Erin mentioned during her presentation, that basically define what these domains of preparedness are. However, I think that once again, this is not a list of questions that should be taken without a critical approach. The assessor, the judgment of the assessor is absolutely required. It's necessary. It's not the tool itself. It's not a series of tick yes or no that gives you an answer. It's really an exercise that should put the assessor in a position where he has, or the team has to use their judgment to provide those scores. So what I'm trying to say is that if a cyber attack is identified as a risk, that risk can be translated into a series of functions that are disrupted. And therefore, if you identified what are the consequences of the cyber attack, then you can also match what are the domains that are most affected by those consequences and therefore reinforce them. So maybe the set of questions as they are right now, they don't mention that, but a skilled assessor can turn them in the way that is fruitful for that type of interrogation.
Thank you, Federico. One more question. Is the survey for armed conflict areas, or do they include natural disasters?
Nope. It's this is we really try to keep it simple and to not overlap with other existing tools. So in this case, what was mentioned that the Hospital Safety Index designed by WHO, in particular the Pan American Health Organization, is really the main reference for assessment of natural related hazards. So very strategically, we said, okay, this is already a very robust and authoritative tool that exists. Let's try to make something that focus on something else, on security related events that are connected to violence and war situation. So we really try to focus on those, and in particular what I mentioned, the expert weighting scores were produced really based on the experience of the ICRC in war-affected areas. So it's really bringing an expertise based on that type of experience.
Thank you, Federico. We have a question here. Are you planning to collate and analyze the data from facilities that you use this tool to give you a global picture of the risk?
As I said, this is not on the table right now because the way at least the ICRC works is really a decentralized way. So delegation in the countries and what we call the subdelegation, or let's say more peripheric office, they really have the highest level of autonomy. So this right now is a tool that is an answer to a need that was raised some years ago. And people are, let's say, free to use as they see fit. However, of course, we all acknowledge that data gathering would provide insights of a global situation that might provide really interesting, as I said, insights. The tool is actually could be easily used to transmit this information. So everything is ready if we want to do it. right now, it was decided that for the time being, the main focus is to really provide operational support to our people in the field. And voila, if the willingness will come, we are also ready to provide a general census of what is being assessed, but well, it's not on the table as I speak.
Thanks, Federico. Someone is asking, are there any specific section for EMS and transportation?
Ambulance. Yes, in the sense that the end point of the ambulance is the health facility. If that is the case, first of all, you need access to road access to the facility, and then you have the interface between the outside world and the facility, that is the gates, the monitoring, the organization of all these crucial points. So the facility is indeed asking about those things, but is not asking about for example, what is the level of organization of the ambulance system in the city of where the facility is located? It's really, it put a boundary on the facility, but of course the facility needs to be plugged to this to the system of first responders, but it's not looking to that system itself.
Thanks, Federico. So Eric Dudenbeck, CEO of IHF, is currently with us in the webinar, and he just wants to say a few comments. Eric?
Yes, thank you very much, and congratulations, Erin and Federico, for your presentations. I just wanted to add a few elements on this great tool that was developed by ICRC. If definitely the tool has been developed to respond to the situation of conflict zones, I believe that it does much more than that. And that's why I really wanted to insist and step in from the point of the International Hospital Federation. We all in healthcare organization needs to be prepared to face risks and to mitigate those risks. And this tool is a great entry point tool to do an initial assessment, which is not too complex. As Federico presented, you know, you don't, according to the level of complexity of the organization, you may need to have people that have some engineering skills, but as long as you know well your organization and your hospital, you can really do the assessment. And this assessment is covering quite a lot of risks, and therefore it allows, as Federico said, to engage, to start a solid dialogue within the organization, to bring up, you know, on the front screen, if I can say, those risks that a number of stakeholders, and I'm thinking often of the clinicians who would be, you know, more wanting to push the discussion around having more equipment to respond to the need for diagnosis and treatment, that the hospital may need to invest to protect itself. So from that point, I really believe that, you know, it goes far beyond the situation of conflict. And somehow I would like to take an example for that to just mirror the example that Federico has given about, you know, bombing. You know, bombing, at the end of the day, it's a blast. If you are near what is called an industrial risk, that means if near the hospital you have, you know, potentially some factories, or you have a large place where you have gas or things like that, you have a very important industrial risk. The consequence of the industrial risk is the blast, which is about the same consequence that the bomb. So therefore, you know, assessing in regard to this man-related risk, because that's a man-related risk, industrial risk, is also something that you can consider even if you are not in a situation of conflict. So therefore, the tool is much broader than what it was initially designed for, and that's the reason why we really are promoting it, because it is really a great, easy tool to have a grip on, to start to do an assessment that is not so costly in terms of time and resources for an entity, and allows really a very solid discussion on how you can better mitigate your risk and increase the resilience of the healthcare organization. Definitely, the Hospital Safety Index is a great tool also, but it is a very complex tool, and because of the complexity, when it's not a government-led initiative where the government is really putting a lot of resources to train the people that are going to be a third-party surveyors that are going to do systematically these hospital safety assessments, which of course is a great thing to be doing. Having the tool like the one of prepared by ICRC as an entry point would allow the hospitals that would be a little, hesitant to go to the Hospital Safety Index to perhaps be more willing to invest in trying to do the Hospital Safety Index, even though this is not an initiative that is led by the government. And that's good, of course, for all the private hospitals or even the public hospitals in situations when it's not government-led. So that's why also it's very well complementing the other tool, because I would see it really as a entry point and one that there is no excuse not to do it. And that's why we really are thinking it's a great tool, and we really advocate for it. Thank you.
Thank you, Eric. Federico, do you have any additional comments before we proceed to the other questions?
No, it's okay.
Okay. We have here a question from one of the participants. Has a survey been done in Afghanistan? And if yes, are you able to share the facilities that conducted the survey?
Yes, I think that some of the examples have been used there, but as I said, for the time being, the use and the results of the assessment are let's say left at the field level. Even here in Geneva, we do not have the results of all these assessments because there are of course concerns about the use of this information, about how it's spread, etc., etc. So yes, as far as I remember a couple of situations where the tool has been used, but no, we can't share.
Okay, thank you, Federico. We have here from Margaret from Nairobi Hospital, Kenya, in Africa. She says in Kenya, they have risk of attack by Al-Shabaab, so man-related risk. Does the use of technology like camera and videos increase security in health facility?
Yeah, indeed, certain technologies like cameras are functional to increase the level of monitoring and therefore of security management of the facilities. And indeed, they are mentioned in the relevant question, in the relevant scoring, as something that brings up the score of the facility that is actually implementing these measures. What is important to realize is that this tool is meant to cover an extremely wide range of, first of all, facilities, and then countries, context. So what is, and this, if you want, it's really the main challenge that we face when we develop the support material and the tool itself. It's really required that the assessor is able to identify what the function is. Therefore, yes, I need to monitor who is entering or passing through the gate of my facility. In one context, CC cameras are a perfect and economic means to do that. In other contexts, they simply might not be available. So something else needs to be put in place. So it's really up to the assessor to use his or her knowledge of the context, of the facility, of the means that are available to scale what the situation on that specific issue is in that given context. So voila, it's really not one specific technology, but it's how we make sure that that function is fulfilled.
Thank you, Federico. I have a question for Erin. Erin, you mentioned the community of action for security of health facilities earlier. So for those who are interested, how can they engage in the community of action?
Okay, so thank you for this question. The community of action really has created this tool and really contributed a great deal to this, but we are at a spot where it's sort of completed this task, and we're going to be phasing this very specific community of action out. However, we'll continue to certainly market this tool, and to the extent that we can draw in feedback and results. But for those that might be interested in learning more about what the community of action has accomplished, or any questions somewhat related to that, I really encourage you to email us, and that we can provide more information on what this community of action has done, as well as any future activities that might be developed, again, in the context of how can we better operationalize these tools for the local level.
Thank you, Erin. All right, so since we have a few minutes left, for anybody who still has questions, you can contact Federico and Erin after the webinar. We will be sending their contact details next week together with the recording. So before we end the webinar, Erin and Federico, is there anything else that you want to share or say to our participants?
You know, this is Erin. I wanted to just summarize and reiterate one of the points that Federico provided, which was the value of those that are conducting these surveys. And it's really less about any one specific skill that any one of us might have, and more about the knowledge of the context and of the facility. And in a second point, echoing a comment that Eric made, that we know that some of our hospitals in the field are using the survey, have used the surveys at multiple facilities, so that they can look at strengths and or areas that need to be strengthened in tandem. So from a more community-based planning level, which I think really speaks to the point that Eric was making about the value of the tool, and how when used in multiple areas, it can really contribute to a broader scope or a broader understanding of the vulnerabilities in a community. The final thing I wanted to say is our thanks to you again, the International Hospital Federation, Eric, for leading this community of action, and that if there are any questions at all, I've provided both the email for myself as well as Agnieszka in the slides, and we welcome your comments and we welcome your feedback. So our thanks to you all for participating.
Great. Thank you as well, Erin, Federico, and to ICRC for doing this webinar with IHF. We really appreciate the time you allotted to share about the security survey. I'm sure that everybody learned a lot, and I know that many healthcare facilities would benefit from this tool. We would also like to thank everyone for joining the webinar today. We will be posting the video recording on the IHF website next week. We will send you the link to the recording and the link where you can download the securities survey via email. But the link is also displayed on the slide right now. So after this webinar, you can already go to the website of ICRC and download the survey. So we hope you can join us again in our future webinars. Next month, we have a webinar which will share a better model to predict in-hospital mortality, and that will be presented by the Health Roundtable. We will be sending more details about that soon. So Federico, Erin, thank you very much again for doing this webinar with us. And thank you again to everyone. I hope you all have a great morning, afternoon, or evening ahead of you.